Hello, everyone. My name is Vadim Koshkin. I'm a GU medical oncologist at the University of California, San Francisco, where I help co-lead the bladder cancer program from the clinical side. And a lot of my research focuses on bladder cancer. So metastatic urothelial carcinoma has been a very dynamic treatment space and a treatment space with a lot of new advances just really over the past few years and literally over the past few months. Over the past few months, a new regimen has been approved for frontline treatment of probably most patients with metastatic urothelial carcinoma, and that's a combination of enfortumab vedotin and pembrolizumab. But it is important to highlight that most of these patients are still not cured, and most patients actually do not receive second-line therapy, which again, on the one hand, makes first-line therapy especially important and selection of frontline therapy, but also makes biomarkers very important and specifically highlights the importance of treatment selection for initial lines of treatment and specifically areas in which we can use biomarkers to better select patients for a treatment with specific drugs. Currently, the only really approved biomarker, or I should say a biomarker that informs therapy that is part of the standard of care, are alterations in FGFR3, because that indicates treatment with FGFR inhibitor called erdafitinib. However, what we know is that in the real world setting, many patients are still not tested for this biomarker. And additionally, many patients who are potentially eligible based on the results of the testing actually do not end up getting the drug erdafitinib that is indicated. We also know that patients with tumors that have high tumor mutational burden, so highly mutated tumors, may have better outcomes with immune checkpoint inhibitor treatment. We've been looking at PD-L1 as a biomarker in metastatic urothelial cancer, but that has been an inconsistent biomarker at best. So at this point, we really need better and additional biomarkers to select treatments for patients with metastatic urothelial cancer. So routinely, we don't unfortunately test as part of standard of care patients with metastatic urothelial cancer for HER2. However, just based on recently published work, we're learning more and more that many patients with metastatic urothelial carcinoma do have expression of HER2 in their tumor, and a subset of patients actually have high expression. So specifically, there was a systematic literature review just from a couple of years ago that took a look at basically all the published literature in this space and highlighted again the significant variability in testing paradigms, and so who tests and which tests they use, basically. But it did highlight that HER2, well, I should say, first of all, patients with any HER2 expression probably represent, at least across this systematic literature review, probably a third or even more of all patients. But moreover, patients with high HER2 expression, so high degree of staining with immunohistochemistry with 3+ or 2+, and FISH positive, those patients represent probably about 15% of patients as well. And so furthermore, there was another study actually that specifically took patient samples, so samples of patients with metastatic or advanced urothelial carcinoma, and used urothelial carcinoma specific laboratory methods to investigate specifically this question, so the HER2 expression in these tumors. And what actually I was involved in this study, and what this study found was that almost half of all urothelial cancer samples had some degree of HER2 expression, so IHC of at least 1+. And again, about probably around 15 to 20% or so had high HER2 expression. And again, this is relevant because all these patients potentially may be eligible for newer generation of HER2 targeted treatments that we will discuss subsequently. So there are a number of ways that HER2 expression can be assessed. And in this, we've learned a great deal actually from other tumors where there's been a longer history of doing this, both in breast cancer and now in gastric cancers as well. The primary way of measuring actually protein expression on the surface of the cells is through immunohistochemistry. This is also confirmed with fluorescence in situ hybridization, or FISH. Increasingly, as we also use more next-generation sequencing panels, including commercially available panels, we're able to detect the amplification of genes that drive HER2 high HER2 expression, namely the amplification of the ERBB2 gene, which encodes for the HER2 protein. But again, it must be highlighted, there's a current lack of standardized methods for assessing and defining HER2 status, specifically in urothelial carcinoma. There is ongoing research in this area because there is significant need for standardization. And additionally, we're learning more and more that other biomarkers detected on next-generation sequencing platforms may also indicate high HER2 protein expression. But again, much more needs to be learned about that. This is a great question, and here I must highlight that the data is pretty inconclusive on HER2 as a prognostic marker in urothelial cancer. There are some studies suggesting that HER2 overexpression is associated with inferior outcomes. But again, these have been retrospective studies and or things like meta-analyses. And so I would say we really just need to learn more about what high HER2 expression implies for the underlying biology of the disease. So how aggressive a given cancer will be. So I say at this point, it's unclear whether we can reliably use this as a prognostic marker in urothelial cancer, the way it's used in some of the other cancers. But potentially, and if we have effective treatments, it could be used as a predictive marker, potentially predicting responses to specific therapies. The history of this actually of specifically HER2 targeted therapies for urothelial cancer and for trials investigating these therapies dates back probably a decade or two, and there were various trials of specific HER2 antibodies like trastuzumab, also some tyrosine kinase inhibitors like lapatinib in metastatic urothelial cancer that actually didn't produce the results we were hoping for, didn't show them to be very effective therapies. But increasingly, there are actually newer generation of agents, so antibody drug conjugates specifically, and I'll get a bit more into what those drugs are, that may be more effective and may be better drugs to target HER2 in metastatic urothelial cancer, in advanced urothelial cancer in general, and potentially in other malignancies as well. And so these antibody drug conjugates are complex drugs. They usually are essentially comprised of an antibody that targets a specific protein, in this case, of course, HER2, and they're linked via linker, which can be a cleavable linker or a non-cleavable, like a covalent linker. They're linked via that linker to a what's called a chemotherapy payload. So specifically, the chemotherapy drug that is then delivered to the cell expressing HER2 in a targeted manner and produces the desired therapeutic results and hopefully allows us to target a bit more selectively the tumor rather than normal tissues. HER2-targeted drugs in urothelial carcinoma have shown a lot of promise, and increasingly we're generating more and more data from actually clinical trials ongoing in this space right now. There are several antibody drug conjugates targeting HER2 that, although they're all antibody drug conjugates, actually differ quite a bit in their various properties, such as what their payload is, so the payload chemotherapy that is delivered to tumors expressing HER2, and of course, what the linker is. These drugs are also in different stages of development, and we have more data for some of them rather than others. So I'll focus on a couple of drugs with the best data in this space right now, and or perhaps the most mature data, I should say. One is a drug called disitamab vedotin, which is an anti-HER2 antibody linked via a cleavable linker to a payload of a drug called MMAE. which is a taxane-type drug or a microtubule disrupting agent. And so with disitamab vedotin, there has actually been studies done in China that had shown pretty robust responses, particularly in patients with high HER2 expression, so IHC 3 plus or 2 plus. The response rates there were actually a bit over 50%. But with this drug, we've even seen responses in tumors with lower HER2 expression. So tumors that IHC 1 plus, responses were still almost 40%. And so based on these initial data that were generated again from trials in China, and this was well over 100 patients, so pretty robust data sets. But now we have further trials ongoing that are global studies investigating the role of disitamab vedotin in this patient population. There's also trastuzumab deruxtecan, which is, of course, also an antibody drug conjugate with an antibody targeting HER2, but a different antibody than what disitamab has. This is specifically trastuzumab, a well-known HER2 targeting drug, and it's linked actually to a different chemotherapy payload, to a topoisomerase inhibitor. And so there was pretty robust data presented with this drug as well in a large pan-tumor study that again showed responses in HER2 expressing patients or in patients with HER2 expressing tumors, I should say. Response rates were about 40%. There are a few other antibody drug conjugates in development as well, including trastuzumab deocarmazine. There's another drug called MRG-002. And another drug called trastuzumab emtansine, which is also approved in breast cancer, has also been investigated. Activity of those drugs has been variable. Trastuzumab deocarmazine in a smaller trial had actually less robust activity. MRG-002 had more robust activity. But again, we just have to learn more about these different drugs. And generate more data basically from larger trials and larger data sets. Increasingly, these HER2-targeted antibody drug conjugates are also being investigated in combinations. And important combinations I'll note are those with immune checkpoint inhibitors. So disitamab vedotin, which I mentioned earlier, was also investigated in combination with toripalimab, an anti-PD-1 antibody, also in a clinical trial done in China. This was about a 40-patient study, and response rates were pretty robust. They were around 70% with pretty reasonable long-term clinical outcomes as well. And again, this robust response rate of about 70% is pretty similar to what similarly designed trials of, for instance, enfortumab vedotin and pembrolizumab have shown. So this really suggested that this combination of antibody drug conjugate targeting HER2 and an immune checkpoint inhibitor may have a future going forward. Trastuzumab deruxtecan, the other antibody drug conjugate I mentioned earlier, was also investigated in combination with nivolumab. Here, the response rates were about what we see with trastuzumab deruxtecan alone, although again, this is a somewhat different patient population, perhaps a more heavily pretreated patient population. But again, this just highlights that these different antibody drug conjugates have different responses when combined with immune checkpoint inhibitors. And these responses are probably impacted by the various components of the drug, such as the type of linker used and, of course, the type of payload chemotherapy used. So HER2 targeting drugs are at this point not yet approved as a standard of care in advanced or metastatic urothelial cancer, or really at any part of the urothelial cancer treatment paradigm. However, I really do think that probably might change in the future. We're having a greater and greater recognition that more urothelial cancer tumors express HER2 and express it to a greater extent than previously appreciated. So there is really a subset of this population that probably will benefit from HER2-targeted therapies. And of course, patients with higher HER2 expression, again, that could represent somewhere between 15 to 20% of the population with metastatic disease overall. Those patients may derive pretty significant and potentially even long-term benefits from treatment with HER2 targeting agents, either as monotherapy or in combination with immune checkpoint inhibitors. So I really think that this next generation of HER2 targeting drugs may lead to changes in the standard of care for metastatic urothelial cancer, and that going forward, we will see more of a patient selection based on biomarker like HER2 expression, and potentially prioritize such patients for treatment with HER2 targeting agents. And I think that may be on the horizon even over the next 5+ years or so, so the relatively near future.